Good evening, everyone, and a very warm welcome to today's webinar on Unveil the Breakthrough Dual Power of Elobixibat, first in class, pro-motility and pro-secretory properties for the treatment of chronic constipation in adults. So today our agenda will be an introduction by me. I am Dr. Bushra Hassan Khan, Senior Regional Medical Advisor at Dr. Reddy's and hired for the Recurra new launches. Then there'll be a talk on constipation management, unmet needs, and introduction to Elobixibat by Dr. Ramesh Roop Rai, sir, followed by a presentation on the clinical trials on Elobixibat, Indian and global perspectives by Dr. Mukesh Kalla, sir, followed by a question and answer session. And I would request our viewers to place their question and answer so that our eminent speakers can answer them, and then followed by a vote of thanks. So today we have with us two notable speakers. So I would like to welcome both of you, sir. And Dr. Ramesh Roop Rai, sir, is a formerly professor and head, Department of Gastroenterology, SMS Medical College and Hospital, Jaipur. He has got a vast experience of more than 45 years. He is a member of editorial board of World Journal of Gastroenterology. From 2002 to 2009, he served as a member. Then he was also the president of the prestigious Indian Society of Gastroenterology from 2007 to 2008. Then he has also been the chairman of the ethics committee of Rajasthan Medical Health University. He has more than 120 scientific papers in peer-reviewed international and national journals. He's also a member of Diplomat of National Board. I welcome you, sir, to this webinar. Then we have with us our most respected and revered Dr. Mukesh Kalla, sir. He is a director and gastroenterologist at S.R. Kalla Memorial Gastro and General Hospital, Jaipur. He is also the principal investigator for the phase 3 randomized controlled trial of Elobixibat in the Indian patients. He has got a vast experience of more than 25 years, and SR Kalla Hospital was an initiative of Dr. Kalla, and it was the first private hospital dedicated to advanced gastroenterology with the dream of developing a teaching hospital and academic center. He is also the pioneer for organ plasma coagulation, cholangioscopy, spyglass, laser lithotripsy, third space endoscopy in the state of Rajasthan. And he also holds extensive research experience as an investigator in clinical trials involving diseases like ulcerative colitis, erosive esophagitis, among many others. So I would like to welcome you, sir, to the webinar, and thank you so much for joining us today.
Thank you for making us part of it. Thank you.
So a brief about the background of chronic constipation. As we all know that chronic constipation significantly impacts the quality of life of many human beings, and the available treatments for the chronic constipation, they typically focus on a single mode of action, and therefore there are many unmet needs in the treatment of chronic constipation because comprehensive symptom relief is not provided by the currently existing drugs. So Elobixibat is the first in class bile acid transporter inhibitor, and it stands out among others because of its dual mechanism of action. It offers both pro-motility and pro-secretory properties, offering a significant advancement in the treatment of chronic constipation. So this webinar will explore why Elobixibat represents a breakthrough in the chronic constipation management backed by clinical evidence that demonstrates the efficacy and safety of Elobixibat in improving the patient outcomes. So with this, I would like to hand over to our eminent speaker, Dr. Ramesh Roop Rai, sir, to kindly present his slide.
Good evening, everybody, all dear colleagues. Today, we are at a stage when orchestrating, that means to move the colon in right direction, that once it contracts, the other part relaxes and other part contracts and the next part relaxes. So there is a movement of the colon. So we need some master stroker to make the colon move in right direction. It's a very complex thing. And as Dr. Bushra just told, that almost about one third population or one fourth of the population of all over the world has sometime or other time has constipation. So it's a complex disease because it has got many components which are there, and out of them we'll try to analyze them today and make it go through. So our webinar agenda is unraveling the complexities of chronic constipation, navigating the current treatment landscape, and Eloxibat, a breakthrough IBAT partial inhibitor with dual action of induction of colonic motility and fluid secretion. And the next part is going to be taken by the principal investigator of the Indian trials, and he will be giving us insight into how it has been useful for the Indian patients. As you know, chronic constipation definition is very difficult to make because everybody has got a different notation of his symptoms, making it a very diverse thing. So Rome came forward with a definition for chronic constipation that if somebody has got 25% of bowel movements, has got 20%, 25% of bowel movements in its whole time, that has got type 1 and type 2 type of Bristol stool type. That means it is a hard stool, it is lumpy stool, it is very difficult to be expelled, and this is called as IBS-C. And also, the frequency of stools has been mentioned by the Rome as less than 3 motions per week. For Indian patients, it's very difficult to understand what they want to tell about their constipation. If somebody has got incomplete evacuation, somebody has to strain, somebody passes less amount of stools, then he tells that it is a constipation. So it's very different for different people. Indians has got a mindset since childhood that they should have one good motion in the morning. If they don't have, they have the whole day going waste. They are so irritated. They are harsh to other people. They are harsh to themselves. So it is affecting the quality of life of a person. So if we find that if a patient has got type 1 and type 2 type of stool, it is chronic constipation. But for Indians, the various study and the various Asian studies have shown that as we are consuming more of milk, more of fiber, so our stool is not that hard. It could be smoother. That means the type 3 also is included. If we include only type A, type 1 and type 2, almost about 35 to 50% of patients would not be included into the definition of chronic constipation. So henceforth, we have to take into cognition and show this chart to our patients. This type of stool are they passing every day? Then, if somebody is having straining, lumpy hard stool, sensation of incomplete evacuation, sensation of obstruction or blockage, maneuvers of digital maneuvering by putting their finger inside and evacuating, a pelvic floor support if it is there, and of all, less than 3 movements per week is called as constipation, and it should be longer than 4 weeks. Another important thing is that if somebody has got 2 of these features, then he can be called as having constipation. So this constipation is a varied presentation, so we have to analyze it in greater detail. And this is three types. That means one, where the colonic transit is normal by the various studies. That is called as primary constipation. Sometimes it could be slow in hypothyroidism or some diseases in which the myoelectric function is not good, then it is called as slow transit. But the most important one, which we are encountering in everyday practice, is defecatory disorder. So if you have a straining and you have a sensation of bolus or something, some people will say that I have got a obstruction inside, a lump inside, I have got some tumor inside, which is preventing my flow of the stool. So this is primary constipation, and secondary constipation is that in which we have what we call as the colonic carcinoma, colonic strictures, or some organic diseases there. This is called as secondary constipation. Another important thing, all of we have to understand that constipation, it could be either functional constipation or IBS-C constipation. We usually do not ask the one simple thing that is the patient has got abdominal pain associated with above bowel disturbances. This it should be asked to these persons, and that if the patient has got complaint of abdominal pain and this is relieved by defecation, this is called as IBS-C. But if the patient is having chronic non-organic constipation without abdominal pain, practically means functional constipation. So we can always decide with no pain, functional constipation, with pain, relieved with defecation is called as IBS-C. How common is this problem in India? Various studies have shown differently. In South India, it is little less. In Bangalore, it was reported at 8.7. Then we did a whole pan-nation study. And in that study, we found that it was 18% of the population was having a chronic constipation. And out of them, about 82% of patients had chronic constipation and only 18% had IBS-C. So IBS-C is less common as compared to chronic idiopathic constipation. So as we understand, chronic constipation world over is a problem of about 11.6% reporting symptoms of constipation. It is more common in females, and it's most of the times it has been seen that 65% of patients older than 60% of 60 years of age have this. So as I just talked earlier, that self-perceived constipation is much more common. Out of them, you have straining at stools in 18% and incomplete sense of repetition 23%. It is not only that colon has got some problem, it is the systemic diseases. So it has been shown that 6 out of 10 patients with chronic constipation have associated systemic comorbidities like diabetes, hypothyroidism, organic brain disease. So we have to take into cognition whether this patient is having these comorbidities along with that. Another important thing which we have to understand that age more than 70 years and with female gender, physical inactivity in these group of patients is very important cause of constipation. And another neurological conditions in which the patient is lying in the bed, like Parkinson's disease, multiple sclerosis, and other things, he is having more constipation. Depression is also very important, and GI or CV or musculoskeletal conditions. If somebody has a fracture and is lying in the bed for 6 months, like that, he will have constipation. Post-surgery constipation is also important, but medications are also very important because of the osteoarthritis and other things. And NSAID use and aspirin use is increasing, and calcium channel blockers are also very important. So these are the factors which are essentially aggravating the constipation. But constipation is not a disease of only intestines. It affects the quality of life of patient. It has got a significantly lower subscores for physical, emotional, and social aspect of quality of life. So we have to understand that we have to provide relief to our patients so that they do not have this particular problem. If you talk about this particular whole thing, that it has been shown that most of the Asian patients are dissatisfied with this treatment. And what is the treatment, what current options which are we having? And there is an unmet need for the current treatment options. It has been shown very clearly that efficacy, about half of the patient, as I just mentioned, with the existing laxatives has got unsatisfactory response. Only one action, most of the bulk and osmotic laxatives are having only one mechanism of action, that is they increase the water retention in the colon. They do not improve the colonic movement. Procalopride, on the other hand, got a action which causes increase in the colonic peristalsis. So most of these drugs having only one single action. So what we need is more water inside. We want some colonic stimulants to propel the pulse, increase the colonic motility. They are very important. So long-term safety of these also is also questioned in many of the situations. Say prucalopride primarily is excreted by the kidney, poses a higher risk of adverse events in those patients with renal impairment. Patients with magnesium or milk of magnesia are unsuitable for elderly and renal impaired patients. So 53% of patients discontinue constipation medication due to experiencing diarrhea. So diarrhea is a common thing. Everybody wants a good, smooth bowel movement every day, which gives him satisfaction. So we have to target our therapies in this direction. So what are the treatment goals? We are aiming to give relief and improvement in the well-being of the patient. So primary important goal of ours is improvement of symptoms like incomplete elimination of the stool and difficulty in passing the stool. Everybody wants a very nice, smooth motion every morning. Secondary goal is passage of stools at least 3 times per week for Western population. For Indian population, we need to have one single good bowel movement every day. It should be soft, firm, and without straining. Overall, the goal is to improve the quality of life. We also understand that constipation is not only a disease of the colon and intestines. The upper intestine also is affected. Most of the patients with postprandial distension have got this particular problem along with the constipation. So if we relieve or empty the colon, we improve the motility of the colon. We give diet which reduces the methane production like low fiber diet. There is an improvement in the upper gut symptoms also like postprandial distension, reflux symptoms, and having a decrease in appetite that also can be taken care with the treatment of colonic bowel movement, which is very important. So if we look at the current treatment landscape, we will find that we have got many drugs which are available. The first line of treatment is bulking agent, which are soluble and insoluble fibers. They increases the luminal water binding, increases the stool volume, and softens the stool. But they are associated with bloating. Another important thing is that if the patient has got a very severe constipation, if you give them more bulk laxating agent, then it is likely to get impacted inside, increases the symptoms of the patient. So we have to see that after the disimpaction, we give the bulking agent, not on the first go when the patient has got severe constipation. Second line of treatment is osmotic laxatives, of which lactulose, polyethyl glycol, and magnesium sulfate are considered to be the one of the best ones. They produce a osmotic gradient in the cavity, increases moisture in the cavity, and softens the stool. But they are mostly associated with bloating. Like lactulose has got a lot of bloating, abdominal pain, abdominal distension, and diarrhea is common with polyethyl glycol. Electrolyte imbalance is also quite common in polyethyl glycol. So they are also associated with possible side effects. The third are stimulant laxatives like biscodiol, senna, and sodium picosulfate. Senna was used ever since we have been studying. So it's a very common drug, but it causes stimulation, and repeated stimulation requires more amount of the drug to be taken, more number of neurological paralysis of the enteric nerves takes place, and a stage comes when we give senna for a longer time, it is going to cause a what we call as the most problematic constipation. So it has to be taken care of. The fourth one is the lubiprostone and prucalopride, which have been shown to increase the intestinal fluid secretion and softens the stool. Selective action on 5-HT receptor, which increases the colonic motility, is the function of the prucalopride, but it produces diarrhea, headache, nausea, and abdominal pain. So if we make an algorithm of this, we have to first find out with the detailed history and exclude the drugs and the organic causes. If we find that there are no organic causes, we look for the alarm features in these patients, like the patient has got inadequate weight loss, he has got a decrease in hemoglobin, a patient is having passing black stools or blood in the stools. So we have to investigate these patients with the colonoscopy and other relevant investigation. If we don't find anything and if there are no alarm symptoms, the initial treatment is lifestyle modification. We must understand that fluid is the most important thing. At least 3 liters of fluid should be consumed by every patient who has got constipation. 1 glass of water every 1 hourly should be consumed. That is going to make their life more better. High fiber diet has been found to be very useful. Exercise is important because when we are straining our abdominal muscles, our respiratory muscles, our diaphragm, everybody is exerting and pushing it down. So we need to have good, so we should give them osmotic laxatives, which will be very useful. And if there is no bloating and the patient is not on fiber diet, bulk laxatives like Isarbol, osmotic laxatives like PAG have been found to be very useful. If there is a bloating and if the patient has got already on high fiber diet, we should give osmotic laxative like PAG. And PAG has been found to be most useful till today in the treatment of. So if there is a good response, we should continue the treatment. Indian Society of Gastroenterology also has given for the patients of refractory chronic constipation, they have given a very big algorithm. So we must try to read this. So as we have just mentioned, lactulose has got a side effect of bloating. PAG has got abdominal distension, diarrhea. All of these improve the consistency of the stool and frequency of the stool, but it is a liquid stool. Nobody wants to have a liquid stool. So we have to make some use of some drug which can be giving such a good effect that smooth bowel movement is there. Sodium picosulfate has been found to be, but it is not recommended to use beyond a month or so. It is a drug which should be used for emergency relief. Prokinetics like prucalopride have been associated with headache, diarrhea, and a prompt discontinuation has been seen if the patient has got diarrhea. Depression, suicidal thoughts have been found to be very common, and CKD is a contraindication for its use. So there are a lot of treatments which are available, but having a lot of drawbacks. So we have to understand what is the new drug in our armamentarium, which can give more fluid secretions and also cause colonic motility, thereby having a dual action. And this dual action may produce such a good effect on the colon, which Dr. Kalla Saab is going to elucidate to us as to how in clinical trials this drug has fared. So we have to understand how this dual mode of action is going to improve the quality of the patient. So as we know, this drug is a partial blocker of ileal bile acid transporter. So enterohepatic circulation takes place in the ileum. That most of the times the bile acids which are secreted from the liver, they reach to the colon and they are getting reabsorbed in the ileum. So if this is enterohepatic circulation, but if you give the Elobixibat to a patient, this is a partial blocker of this ileal receptor for transportation. So Elobixibat inhibits IBAT in the ileum, thereby increasing the concentration of bile acids in the large intestine. Right? So this is going to cause a increased bile acid in the colon. This thereby increases the colonic secretion, increases colonic motility, and you can find that increased bile acids in the colon boost motility and secretion. So this motility is also affected, and also the water secretion which is induced by the presence of the bile acid in the colon is going to cause lot of fluidity to the fecal matter, and also is going to cause a good propulsive movement, the increasing by the motility of the. So there is a enhanced bowel movement which is taking place because the volume is increasing. When the volume increases, the colonic contractility also increases, and the motility also is improved with the use of this particular partial uh, uh, ileal bile acid transporter blockage, which is taking place in the ileum. So it has got a three-fold action which is there, and we'll talk more about this in details. As we know that this increases the stimulates the intracellular mediators, increased intestinal permeabilities. The aqueous channels have also been shown to increase with the use of bile acid inhibitor, and enteroendocrine system is also affected, thereby increasing the serotonin. This is a motility drug which enhances the high action potential contractions of the colon, thereby increasing the frequency of colon propagative pressure wave, and it is sequential in mechanism. It increases colonic mass movement. So it has got a multiple action which is taking place, increasing secretion, increasing motility, increasing the contractility of the colonic musculature, producing high pressure frequency propagative contractions of the colon, and thereby increasing the movement of the stool in the gut. So it has been shown that this drug has been very useful as a bile acid inhibitor, and its absorption, and thereby it produces a good effect on this. Another very important thing which is there, that it is not absorbed in the from the colon to the blood, and therefore it has not been producing any bad side effects. And additionally, Elobixibat does not induce drug resistance because it is not going to the circulation, does not cause significant change in the gut microbiota. That is also very important. So it is important to learn that it is a primary elimination through the feces with only 0.01% excretion in the urine, because it is not getting absorbed. So no drug-drug interaction which is taking place, and it's a very safe drug. So safety profile has been there. Side effects are very minimal, and occasionally a patient can have what we call as the diarrhea or pain abdomen. Pain abdomen is one of the most important one, which is in experienced. It's a dose titration is also there. If you increase from 5 milligram to 10 milligram to 15 milligrams, you can have a good sustained effect of the drug, and more drug can be there. Efficacy is consistently that you produce smooth bowel movement, a complete smooth bowel movement, stool consistency is good, and thereby it improves the quality of the life of the patient. It has got some drug-drug interactions, but not very, very important to understand. It has got minimal absorption and low diarrhea incidence compared to other laxatives, and it has been shown that as it is minimally absorbed and excreted in the urine with minimal incidence of diarrhea as compared to other drugs, as you can see over here, it is 0.01% that patient will have diarrhea, as is there with other drugs like sodium picosulfate or lactulose or PAG or flucalopride. So, concludingly, we can say that this has got a action on three places: increases the motility, whereas most of these have got one action only. So it has got an increase in motility, increased fluid secretion, and defecation desire is increased. Drug-drug interaction is minimum with this. Efficacy 92% achieve more than 3 stools smooth bowel movement per week after 2 weeks of the treatment, and even in the first 24 hours also 86% will have a good smooth bowel movement. And safety profile has been shown up to 12 months. It has been shown that Elobixibat has got local action only, whereas others have systemic effects also. Tolerance is minimal. Electric disorders are rarely seen. Safety in elderly is there, so any age group can be given. Diabetic safety is also there. It has got cardiovascular safety, renal safety. As it is not absorbed, it is not going to have. So it has got abdominal pain as one of the side effects, and it is sometimes seen, but it has got no effect on the brain as it is not been getting uh, absorbed. So Elobixibat, the key takeaway points for all of us is that it is effective with proven safety, provides immediate and sustained relief, improves bowel movements frequency, consistency, and quality of life. It has got a unique dual local action, acts locally in the GIT with fluid secretion and colon motility action, minimizing the adverse side effect. Safety profile is established in elderly and patient with comorbid disease like an Indian study, as Dr. Mukesh is also going to tell us, that has got some good effect. Flexibility of doses is there. You can titrate up to 15 milligrams, starting with 10 milligrams, and multifaceted benefits are there. It improves glucose and lipid metabolism also. So it has got lot of additional side effects other than acting on the colon, and no absorption is there. It has got a action in which probably smooth bowel movements, which we are looking forward, will be achieved. And Dr. Kalla Saab is going to tell us as to how the things are moving in the clinical studies. Thank you very much for your kind hearing.
Thank you, Dr. Ramesh Ruprai, sir, for your valuable insights on constipation management and Elobixibat. And your expertise has greatly enriched our understanding and will guide us in better patient care. We deeply appreciate your time and contribution, sir. So I would now like to request Dr. Mukesh Kalla, sir, to kindly present his talk.
Yeah, thanks at the outset to Reddy's Lab for having given us this opportunity to speak and read about in depth about this molecule. Sir has almost practically given a very comprehensive overview of this topic. So my responsibility is to take you through the scientific data which this molecule has to give support to the clinical use of this particular molecule. So we have to understand that almost quarter of our population has this constipation problem, and whatever is the available armamentarium we have, the pharmacological methods and the lifestyle modification leads to almost at the max 50% satisfaction. 50% of the population is still unsatisfied with the outcome of the available therapies. Therefore, there was always unmet need to have a better molecule, and this thing is, I think, a very important disease because the quality of life is severely affected in this particular problem. So we must thanks the Japanese people like vonoprazole, which they are using for almost now more than a decade there. So they were using this molecule since 2018 when the first study which was published from Japan. The molecule was first introduced in 2013, and the first presentation and the first phase 2 trial which was published in 2018 in Journal of Neurogastroenterology, where like we have two studies to quote here. Study one, which was of 69 patients, and which was like a placebo-controlled RCT for 2-week treatment of these patients at a fixed dose of Elobixibat of 10 milligrams. So what was observed was, we'll get to know. The other study is study two, which was an open label long-term study of 340 patients for a 1 year treatment period, where three doses, 5 milligram, 10 milligram, and 50 milligram were studied. And the relative safety, type, severity, and the relevance of, safety profile of this drug was studied in and published in 2018. So when we went inside the depth of this publication, we realized that patient had their first spontaneous bowel movement within 24 hours of taking this medicine. And the complete spontaneous bowel movement started happening within 24 hours only. That is to say that this drug has quick action, and the frequency, if you see the chart on the right side, so this was the placebo and this was the effect, this was the placebo and this was the effect. So you'll realize that statistically significant response to the spontaneous bowel movement as well as complete bowel movements were appreciated right from day 24 hours. If you see this, within the first week, the response started happening, and there's a sustained response up to week 2 was observed in the first study, which was a placebo-controlled trial. Now, whatever we were discussing about constipation treatment, this stool scale comes in use always. The best part of this particular molecule was that it was able to sustain a type 4 kind of a stool consistency. So this is something which satisfies a patient, because all other kinds of, the medicines which are used for treating the constipation would either create diarrhea or will create pain. So the most quality of life indicator which will satisfy a patient is to have a type 4 kind of a stool, which is easy to pass and doesn't give a patient a problem. If any drug which can give you a response within first 24 hours and this response is sustained, and above all, if you can get a response of type 4 kind of a stool, then this is the right kind of medicine, I would say. So when you see the response of these two medicines about complete spontaneous bowel movements and spontaneous bowel movements, you'll appreciate that this drug holds good in both the situations. Another implication of this study was when compared to placebo, Elobixibat, the rescue medication requirement was practically insignificant at week 1 as well as on week 2 as well. So the Japanese criteria for quality of life indicator was assessed for these patients. In the other study where we had more number of patients, these criteria were studied at 4 weeks, 12 weeks, and up to 52 weeks, which is almost more than a year. So we appreciate with this chart that the quality of life index was reasonably well maintained in these follow-up weeks for these patients. Moreover, the satisfaction score was also significantly better for these patients who were taking Elobixibat to relieve their problem. Elobixibat in the long-term study, where it was studied at doses of 5 milligrams, 10 milligrams, and 15 milligrams, was also found to have a safety in short term as well as in a long term as well. The most commonly observed side effects were diarrhea and some pain. Even these symptoms were not disabling symptoms. The 61% of the symptoms got resolved with dose changes and 25% resolved by dose reduction. Therefore, to say that at the most this medicine you may need to reduce the amount of dose which the patient is taking to relieve the side effects. The frequency of these side effects wasn't great because it was less than 4% in all the patients. This is Elobixibat is primarily eliminated in feces. The best part of the medicine is that it is not absorbed. It does not have any drug-to-drug interaction. It does not interfere with other comorbidities as well. We'll talk about it in subsequent slides. Now, Elobixibat outperforms placebo in enhancing bowel movements in Indian population. So before this molecule was permitted to be used in this country, Redisloab initiated a DCGI controlled trial. Fortunately, we were also part of this study. So when this study was a short study and not many patients in this study, but Elobixibat increased the weekly spontaneous bowel movement frequency significantly better than the placebo. The complete spontaneous bowel movements with Elobixibat against the placebo was also significantly better. So in case of Indian population, if you see these charts, these patients having SBM within 24 hours, again, Elobixibat did pretty well as compared to placebo. Now, these were the significant side effects which were observed: dry mouth, some abdominal pain, diarrhea, in these patients, which was insignificant. And as we had discussed in the last slide, even these side effects, when present, were settled down by reducing the dose or altering some amount of the medication patients were taking. Therefore, to say that Elobixibat was well tolerated with no significant safety concerns over 2 weeks once daily treatment in Indian population. Elobixibat demonstrated safety and efficacy for elderly with chronic constipation. When you go through the data of constipation patients, you will appreciate that with the passing age and with the more in females, the problem gets worse. So therefore, we need a molecule which is safe to be used in elderly population. Therefore, when you go through this data, you'll appreciate that when you have an elderly group aged 65 plus and 75 plus, there were significantly more bowel movements per week and higher mean Bristol scoring scores at week 2 and 4 compared with those at baseline. Therefore, it is well tolerated in an elderly person with only side effect of 4.46 to 3.58% in an age group of 65 and 75 years, more than 65 and 75 years. That is to say that a subgroup of patients who are more likely to have a severe kind of this problem are also good to take this medicine because this medicine is safe for them. Elobixibat improves the rectal sensation thresholds. Now, this is very important. When Dr. Raya was talking about this slide, he said it improves the desire to defecation. So Dr. Raya said that there were multifactorial use of this medicine. One use was, of course, it was helping you to relieve constipation. Second, it was also helping you to, the bile acids accumulating in the colon, inviting more fluid in the bowel, therefore making the stool soft, and simultaneously start stimulating the bowel colon for a stronger movement, what stimulant medicines were doing. Other than that, the desire to defecation also improves with this medicine. So this was a trial which was published way back in 24, which says that when you have when a patient is on Elobixibat, then desire to defecate, the volume of desire to defecate is 9 ml, which is significantly it reduces the threshold. Therefore, patient develops desire to defecate. The patient's, Elobixibat significantly reduces the threshold to FCSV, which means that when you inflate a balloon in the rectum, the, it is patient is able to perceive the sensation of the balloon easily, which says that the sensation in the rectum, the defecation disorders. When you have a defecation disorder, this drug might have reasonably effect in the defecation disorder, not only in slow bowel movement or those patients who have chronic constipation. So as for comorbidities, you have patients of diabetes, renal disease, heart failure, cancer, and Parkinson's disease. The two subgroup of patients, which is Parkinson's disease, and second is heart failure. So these are two group of patients where there might be a second choice of medicine, but for rest of the disease, it's pretty safe. The collateral advantages of this particular medicine is that it reduces the LDL cholesterol levels. This drug also improves the sugar levels. There are smaller studies available which will require further deeper insight into the subject to suggest that the subgroup of patients who are like having NASH CLD or the subgroup of patients who have diabetic neuropathy, having constipation, or those subgroup of patients who have dyslipidemia, can this drug be prescribed there? But as of now, whatever data which is available to us, which will suggest that this medicine, Elobixibat, improves HbA1c, it also decreases fasting blood sugars. Simultaneously, it also decreases the LDL cholesterol. Therefore, these are the collateral advantages of using this medicine along with constipation. In that subgroup of patients which are suffering from diabetes, who are suffering from dyslipidemia, cardiac illness because of high cholesterol and triglyceride. So we will need further research or insight into the fact that will this drug be reducing the blood sugar and complementing the effect of anti-diabetic medicines and the use in NASH, CLD, etc. Other big advantage of this medicine, Elobixibat, is that over a period of time, the use for saline and stimulant laxative starts going down. So when you start, initially when you start this medicine, Elobixibat, along with other laxatives, over a period of time, you can slowly withdraw saline laxatives as well as stimulant laxatives. So now, when we started in the first trial, which came in 2018, the trial which was the longest trial, 52-week trial, which was conducted on around 340 odd patients, which was tested the safety of this medicine on 5 milligram, 10 milligrams, and 15 milligrams. So it was observed that Elobixibat, uh, even if you increase the doses of this medicine, the optimal effect starts coming at 10 milligrams. The effect, of course, starts coming at 2.5 milligram only, but the therapeutic effect is appreciated well at 5 milligrams. The optimal effect comes at 10 to 15 milligrams. So mean weekly spontaneous bowel movements and complete small bowel movements was consistent across severe, very severe, and absolute constipation. That is to say that if you do use a higher doses, even a severe kind of constipation can be treated with this medicine. and when more patients are titrated at 15 milligrams per dose. The proportion of patients still taking 15 milligram dose in the last 4 weeks of the 52 trial period, there were no notable increase in incidence of adverse drug reactions. So this Elobixibat is well tolerated doses up to 15 milligram for 2 weeks. That is to say that this is 15 milligram is one dose. Up to 20 milligram use has been suggested, but this is that trial which we were talking about. The placebo 5 milligram, 10 milligrams, and 15 milligrams. The effect at 10 and 15 is not greatly different, which I think 10 milligram appears to be a reasonable dose. Start with 5 milligram, go up to 10 milligram to achieve optimal effect of this medicine. So medicine is a science of uncertainty and art of probability. So we have a molecule which has a multifactorial effect. We need to study this molecule in much great detail to to use it at the best possible way. So additional insights, as we were talking, it has effect on the glucose metabolism. It reduces the HbA1c, and it also reduces the average blood sugars from 119 to 98.5. So these are smaller studies. They are not RCTs. More such studies will be needed to confidently say that can we prescribe Elobixibat in subgroup of patients who are suffering from constipation. The subgroup of these patients of diabetes are badly affected by constipation, and they really need some support for relieving constipation. So when I was going through the data on this particular subject, we appreciated that the diabetic patient with a reasonably average BMI do pretty well with Elobixibat as compared to people who are obese or who have a higher BMI. Elobixibat possibly superior to prucalopride for chronic idiopathic constipation. Now, unfortunately, all the kind of multiple medicines which are available in treatment of constipation, we do not have head-to-head trials for them. That is to say that you do not have a trial for bisacodyl versus prucalopride on a RCT level to say that which molecule is better. But the data analysis says that bisacodyl has the most potent effect, and the Elobixibat is better than prucalopride uh, as compared to other like bisacodyl and sodium phosphate and other medicines. The effect is comparable. Dr. Raiser has already mentioned about this line. The good thing about this medicine is that it is not absorbed, is minimally absorbed and excreted in urine. Now, this particular slide also has been discussed by Raiser in much great detail. It's Elobixibat is reliable and well tolerated alternative to traditional laxatives. So I won't go into great detail of this slide. So as to say that before we conclude, it is a suitable option for various patient profiles as the lactulose is locally acting, sodium picosulfate is locally acting, electrolyte disorders are there into these medicines, whereas Elobixibat is safe. Diabetic safety, the data is still, favoring the use of Elobixibat, though more trials are needed. We have papers suggesting that it is safe in renal patients. It is safe in patients on hemodialysis also. The major side effects are abdominal pain and bloating. The suicidal indentations like you have in other medicines is not there in Elobixibat. So conclusion and takeaway for this particular molecule would say that it is effective with proven safety. So far, not multiple trials, but whatever data we have in hand, and use of this medicine for last 6 years in Japan says that it is effective and is a safe medicine. It is unique dual and local action. I would say not dual, multifactorial action. Safety established in elderly and comorbid patients. We have a reasonable trial on this, which says that this particular group of patients are badly suffering from constipation, and this molecule would probably be a boon for them. Flexible dosage, titration up to 15 milligram from 5 milligram is permitted because there are no significant adverse events even after increasing the dose up to 15 milligrams. And multifaceted benefits, improves glucose, lipid metabolism, addition to constipation relief. I wonder, I mean, I was going through the literature because of the mechanism of action of this medicine. There are case reports saying that you can use this medicine for cholestatic disorders also. So we'll have to read more about it and go deeper, dive deeper into more literature to say that it is good for that purpose as well. Thank you so much for kind attention.
Thank you, Dr. Mukesh Kalasa, for your excellent talk on Elobixibat clinical trials from Indian and global perspectives. Your expertise and clarity have significantly increased our understanding, providing practical insights for advancing patient care. We sincerely value your time and contribution, sir. And thank you once again, our esteemed speakers, Dr. Ramesh Ruprai, sir, and Dr. Mukesh Kala, sir, for excellent presentations. We have received a few questions from the audience. And if you have few more minutes, sir, we would appreciate your insights on them.
Surely, please.
Yeah. Sir, based upon your experience, Dr. Rai, sir, so with Elobixibat, uh, where would you place Elobixibat in the treatment algorithm of chronic constipation?
The issue with most of our patients with chronic constipation is that they want a smooth bowel movement every morning. They do not want to strain. They want to have a very feasible way of life in which the quality of life improves in those group of patients. So as we are presently using the drug, which most of them are producing loose watery stools, the quantity of stools also is increasing in these group of patients. These are the group of patients who will probably need a smooth bowel movement. But at the contrary, I would say that chronic constipation patients, they are having multiple problems. It is not a single thing which is happening. They are not
Yes.
having enough water in their colon. Though it is increasing the water or stimulation of the water secretion in the colon, but this impaction is going to be a tough problem for chronic constipation patients. Most of these patients have got a colon. If you take a scout colon, I will advise every one of the physicians who are attending, a gastroenterologist who are attending, that every patient of constipation, you should take a scout standing and lying down position X-ray, because it is going to tell you how much stool is getting stuck into the colon. Because a small amount of stool is passed, the patient is not feeling satisfied. And at this time, you need disimpaction. Give as much as possible polyethyl glycol as you do for the colonoscopy, disimpact it. And then you can put the patient on Elobixibat or other drugs which you like. So I think in the position, disimpaction followed by this drug is going to be more useful, because we have to make the intestine learn that how to contract. So this drug is causing the expansion of the volume of the stool by increasing secretion. It is increasing the motility, so it is going to have good contractions. And as such, if the volume is more, the muscle, say, I usually give an example that if the spring is made this much distant and you release it, there is going to be a very little impact. If you have got colon muscle stretched to this extent, then if you leave here, you will have a good impact. So this drug is going to give that satisfaction to our patients.
It's a wonderful response, sir. Thank you so much. Sir, I would like to direct one question to Dr. Mukesh Kala, sir. Sir, even though we have a 52-week study on Elobixibat, so as per your understanding, what should be the ideal duration of treatment for the chronic constipation management using Elobixibat?
Yeah, I mean, that's a pretty nice question, Bushra. I mean, we have data about 52 weeks, and the drug is safe. The drug-drug interactions are not there.
Yes.
And when we went inside the literature, I mean, it can be used safely up to 5 years, and the mean time which can be used safely is 106 weeks, which would be probably around 3 years. You can use it safely without major side effects.
All right. So that is a prominent query by
Yeah,
many of
I
the
mean,
practitioners. Yeah.
this was an article which came up in 2024 in BMJ, which says that, I mean, the maximum use which has been documented is up to, I mean, 5 years, and up to 3 years. I mean, it can be used safely, which was the mean duration of time which this drug was used safely.
Also, sir, there is a question in the chat box by Dr. Manoj. He is asking about the safety of Elobixibat in chronic liver disease patients and also in the patients with cholecystectomy?
Yeah, I mean, there's a logical question to say that if you have a cholecystectomy, the bile acid secretions will be hampered and how good this medicine will be there. So we need to understand, I'll address first question, which is the use of this medicine into liver disease patients. Now, since this drug is not absorbed at all and it goes through the feces only, the urinary elimination of this drug is 0.01 only, which is to say that it won't affect your bowels at all. Its effect on changing the microflora of the bowel is also not significantly appreciated, which would say that the translocation of bacteria and risk for SBP will not be higher even if you use Elobixibat. The collateral advantage of Elobixibat would be if you have a subgroup of CLD patients who are NASH patients because of dyslipidemia, it might lower LDL and you give you some benefit. I just found one another study which suggested that over a period of time, if you use it when it was used in NASH patients, there was a marginal improvement into the fibrosis score as well, which was a very, very small study. I would probably not quote it as a statement, but just a part of the literature.
All right.
The
Thank you
most
so much,
important
sir.
thing is
Yeah.
that we must understand that liver is functioning, even if the bile acid, which is getting blocked and it is going through the stool out of the body, the liver has got tremendous capacity to produce the bile acids. So
Yes, sir.
even if 90% of them is blocked, the partial blockage is there. So it is going into the enterohepatic circulation. 10 to 20% is going to be back into the liver, and remaining part will also be produced by the liver. And in the CLD patients, probably it is not going to have effect, as Dr. Mukesh has just mentioned.
Yes, sir. So there is also another question by Dr. Supriya. She is asking about the mechanism of action, safety, and efficacy of Elobixibat, and how do these parameters have an effect on the treatment of the Indian patients? How is this advantageous over the other drugs?
Mukesh,
So,
Indian patients.
yeah. Thank you, sir. So the experiences are limited to few patients under the clinical trial only. Commercially, we have not started using it as yet. So, I mean, there is not a vast experience on this particular molecule in a routine day-to-day clinical practice. But we have discussed it in great detail that there is a scientific basis for using this medicine in a subgroup of diabetics because it is said that it increases the GLP-1 level. So maybe down the line, you may hear from our endocrinology friends that their constipation patients in this medicine is complementing the anti-diabetic medicines as well. It is safe in even hemodialysis patients who are like, dependent patients on for their life. So I'm saying it's a reasonably, as per the scientific data available, it's a reasonably good medicine to be used, which is pretty safe.
Yeah. Thank you so much, sir. I hope the query was answered well. And now I would like to request Sandeep. Sandeep, are you available online?
Yes, yes.
Yeah, Sandeep, I would like for you to just interact with our eminent speakers for today who delivered such a brilliant talk. And I would like to take you, from here. Yeah.
Thanks, Dr. Ushra. And yes, sir, on behalf of the Dr. Reddy's and the entire my team members, sir, I would like to thanks and give our gratitude to both of you for giving such a very, very nice session on the role of the Elobixibat and enlightening the knowledge of the other doctors also who are there working as a attendance here. So special thank to Dr. Ramesh Upra, sir, who always known as a great teacher in entire India and is the most respectable and the great human being. Even I can say even Dr. Mukesh Kalla and the G6 and the other doctors still, Dr. Ramesh Upra, they are still having their teacher.
Yeah.
There is a no option of no to no to Dr. Ramesh Upra, and he is having a sunshine
And this, but
because of this.
yeah, thank you,
And yes,
Sandeep.
Dr. Mukesh
And
Kalla, sir, is an eminent gastroenterologist and one of the top endoscopists of India. And thanks, sir, both of you. And this is a privilege of Dr. Reddy's to have both of you in our platform. Thanks,
I
sir.
would like to add two statements here. I would like to thank Dr. Mukesh Kalla sir as well as Dr. Ramesh Rupray sir. And the particular reason for this is uh, officially my first webinar presentation with Dr. Reddy's. So it will always hold a special place in my heart. Thank you, both of you. It was really great to have both of you with us at Dr. Reddy's.
Thank you.
Thank you very much. Thank
Thank
you
you.
very much for
Thanks to
your
Thank
all
you so
doctors
much,
and
sir.
panelists.
Good night.
Thanks.